Hello and welcome. If you are preparing for your CCRN exam, you know that sepsis is one of the most important and heavily tested topics. It's a condition we see every day in the ICU, and understanding it is critical for both patient survival and exam success. In this video, we're going to do a high-yield review of sepsis and septic shock, focusing specifically on what you need to know to answer those tough CCRN questions correctly. First things first, we have to be using the right definitions. The old SIRS criteria are gone. The CCRN will test you on the current Sepsis 3 definitions. Sepsis is now defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Clinically, this means you have a patient with a suspected infection plus an acute increase in their SOFA score of 2 or more points. Septic shock is a more severe subset. To meet the criteria for septic shock, the patient must have sepsis and require vasopressors to keep their MAP at or above 65 and have a serum lactate greater than 2 even after you've given them fluids. Memorize these two criteria for septic shock: vasopressors and lactate greater than 2. To understand sepsis, you have to understand the pathophysiology. It all starts with an infection that releases toxins, triggering a massive, uncontrolled inflammatory response. This storm of cytokines damages the endothelium, the lining of the blood vessels, making them incredibly leaky. This capillary leak causes fluid to pour out into the tissues, leading to edema and a relative hypovolemia. At the same time, this inflammation activates the clotting cascade, forming microthrombi that block off blood flow to organs. This combination of vasodilation, leaky vessels, and tiny clots devastates tissue perfusion, forcing cells into anaerobic metabolism, which produces our key marker, lactic acid. On the exam, you may be asked about the SOFA score. Remember, this is a simple bedside screening tool for patients outside of the ICU. It is not used to diagnose sepsis. It's used to identify patients with a suspected infection who are at high risk for a poor outcome. A score of 2 or more is a major red flag. The 3 criteria are a respiratory rate of 22 or more, altered mental status with a GCS less than 15, and a systolic blood pressure of 100 or less. So what does the septic patient look like? Hemodynamically, they'll be tachycardic and hypotensive. A key CCRN concept is the difference between early and late shock. In early warm shock, the patient is vasodilated and will have warm, flushed skin. In late cold shock, the body's compensatory mechanisms fail and they become cool and clammy. You'll also see tachypnea, altered mental status, which is often the very first sign, and signs of organ damage like low urine output and a rising creatinine. This slide is arguably the most important one for your exam. You must know the 1-hour bundle. These are the 5 critical interventions that must be initiated immediately. 1. Measure a lactate level. 2. Obtain blood cultures, and this must be before you give antibiotics. 3. Administer broad-spectrum antibiotics. 4. Start a rapid 30 ml Polar kg crystalloid bolus for hypotension or a lactate of 4 or more. And 5, apply vasopressors if the patient is still hypotensive to maintain a MAP of at least 65. Let's break that down. Lactate is our single best marker for tissue hypoperfusion. A level over 2 is concerning, and a level of 4 or more is a trigger for immediate aggressive fluid resuscitation. Following the lactate trend or lactate clearance tells you if your resuscitation is working. For fluids, the standard is a 30 ml kg bolus of crystalloid. The goal is to fill the tank that has become leaky and vasodilated. Remember to use balanced fluids like lactated ringers whenever possible to avoid the acidosis that can come with large volumes of normal saline. The rule is simple and absolute. Cultures before antibiotics. You need to draw at least 2 sets of blood cultures from 2 different sites to identify the bug causing the infection. Once those are drawn, you hit them hard with broad-spectrum antibiotics. Every hour of delay in septic shock significantly increases mortality. You start broad to cover all your bases, and then you can de-escalate to a more targeted antibiotic once the culture results come back. What if fluids aren't enough? If the MAP is still below 65 during or after that initial bolus, you start vasopressors. Do not wait. The goal is a map of at least 65 to ensure adequate perfusion to the brain and kidneys. The first-line vasopressor of choice, and you must know this for the CCRN, is norepinephrine or Lavoft. It provides potent vasoconstriction to increase that dangerously low SVR. You can add agents like vasopressin or epinephrine if more support is needed. You will absolutely get a hemodynamic question on the CCRN. You must know the profile for septic shock. Because of the massive vasodilation, the systemic vascular resistance, or SVR, is profoundly low. This is the hallmark. To compensate, the heart pumps very fast against this low resistance, so the cardiac output is high. And here is the trickiest part. The SVO2, or mixed venous oxygen saturation, is also HIGH. This is because even though oxygen delivery is high, the cells are so sick they can't use the oxygen properly. So a lot of oxygen returns to the heart unused. Low SVR, high CO, high SVO2. That is classic septic shock. Sepsis is a devastating illness that leads to multiple complications, including ARDS, acute kidney injury, and DIC. So for your exam, let's summarize the key takeaways. Know the Sepsis 3 definitions. Memorize the 1-hour bundle. Know that norepinephrine is the first-line vasopressor for a MAP goal of 65. And finally, master that hemodynamic profile. Low SVR and high SVO2 are classic signs. Okay, let's put this into practice. Here is a typical CCRN-style question. A 68-year-old male is admitted with a suspected UTI. He is lethargic, with a BP of 84/50, which is a MAP of 61. His lactate is 4.5. You immediately start the 30 ml kg bolus after the first liter of fluid. His MAP is still 62. What is your priority action? A. Give a second 30 ml kg bolus. B. Start a norepinephrine infusion. C. Get cultures and give antibiotics. Or D. Place a central line. Feel free to pause the video to consider your answer. The correct answer is B. Initiate a norepinephrine infusion. Why? Because the bundle says to apply vasopressors if the patient is hypotensive during or after fluid resuscitation. His MAP is still below 65 despite getting fluids. Your priority is to restore perfusion pressure now. Waiting to finish the entire bolus would be a dangerous delay. While the other actions are important parts of the bundle, none of them address the immediate life threat of persistent hypotension. Let's try another one, this time focusing on hemodynamics. A patient in your ICU is being treated for septic shock from pneumonia. They have a PA catheter in place. Which of the following hemodynamic profiles is most consistent with the hyperdynamic or warm shock phase of sepsis? Pause the video to take a look at the options. The correct answer here is B, a cardiac output of 9.5, an SVR of 450, and an SeVO2 of 85%. This is the classic profile we just discussed. The SVR of 450 is profoundly low. The cardiac output of 9.5 is very high, and the SeVO2 of 85% is also very high, indicating that the tissues are failing to extract oxygen. The other options describe profiles more consistent with cardiogenic or hypovolemic shock, which have high SVR and low cardiac output. And that concludes our high-yield review of sepsis for the CCRN. Remember to focus on those key definitions, the time-critical actions of the bundle, and the unique hemodynamic profile of distributive shock. Thank you so much for watching. If you have any questions, drop them in the comments below. Good luck on your CCRN exam. You are going to do great.